Very good morning to all. Today we'll discuss about mouth preparation in complete denture. Mouth preparation is very important when for before the fabrication of the complete denture. Mouth preparation involves first one elimination of the infection, second one elimination of pathology, third one nutritional counseling, and fourth one conditioning of the tissues. First one elimination of the infection. Infections arise from remaining caries teeth, periodontally weak tooth, ulcers, non-vital tooth should be eliminated. Fungal infections like candidiasis, viral infections like herpetic stomatitis, and denture stomatitis must be treated prior to commencement of the treatment. Next one, elimination of the pathology. Patient must be educated and informed about the danger involved if these lesions are left unattended. Tumors and cysts of the jaw should be treated or surgically excised. Next one, conditioning of tissues. Deformed tissues are allowed to return to normal by asking the patient to not wear the old dentures for some time and conditioning of the tissues using soft liners. And the last one, nutritional counseling. Nutritional counseling is essential to prevent any nutritional deficiencies. This is more important for the patient whose metabolic and masticatory efficiency may be compromised. Coming to pre-prosthetic surgery. Coming to definition of pre-prosthetic surgery, it is defined as it is the surgical procedure designed to facilitate the fabrication of a prosthesis or to improve the prognosis of prosthodontic care. Next one, classification of the pre-prosthetic surgery. The pre-prosthetic surgery classified into two types. First one, conditions that prevent optimal prosthesis function, and the second one, enlargement of the denture bearing area. So under conditions that prevent optimal prosthesis function, first one, retained dentition, second one, soft tissue abnormalities. Under soft tissue abnormalities, first one, hypertrophic venum, second one, flabby ridge, and third one, denture stomatitis. And third condition that prevent optimal prosthesis function is bony abnormalities. Under bony abnormalities, extraction and alveoloplasty, ridge undercut, prominent mylohyoid ridge, maxillary tuberosity interference, sharp spiny residual alveolar ridge, tori and esophagosis. And second classification is enlargement of the denture bearing area. Under enlargement of the denture bearing area, first one vestibuloplasty and second one ridge augmentation. Vestibuloplasty done by three methods. First one mucosal advancement, second one secondary epithelialization, and third one epithelial graft vestibuloplasty. So first one, conditions that prevent optimal prosthesis function. Under this, first one, retained dentition. So retained dentition include retained roots and unerupted tooth. And these are assessed through radiographic examination. A decision has to be made whether to retain or remove them. Generally, all retained roots and unerupted tooth are removed. Only those that are located deep within the bone, which are asymptomatic and removal would leave a large defect, are retained, but assessed regularly for any pathologies. And the second one, soft tissue abnormalities. Under soft tissue abnormalities, hypertrophic frenum. And hypertrophic frenum are fibrous bands of tissue frequently attached superficial to the muscle attachment in mandible and maxilla. Hypertrophic maxillary labial frenum attached close to the crest of the ridge. Crest prevent ideal extension of denture borders and peripheral seal. They can also become prominent as a result of ridge resorption. Movement of soft tissue adjacent to the frenum may also create discomfort and ulceration. Providing relief in the labial notch of the denture can create loss of border seal and also midline fracture of the denture. It needs surgical removal. And this is the picture that shows labial frenum, and the first picture shows normal labial frenum, and the second picture shows hypertrophic labial frenum. That hypertrophic labial frenum resulting frenum attached close to the crest of the ridge. Hypertrophic lineal frenum can attach high on the residual alveolar ridge, interfering with the denture extension and stability. It can also attach high on the ventral surface of the tongue, restricting tongue movement, causing tongue tie and speech impairment. In either case, surgical intervention is indicated. And this is the picture. These two picture. First picture A shows normal lingual frenum, and the second picture shows hypertrophic lingual frenum obliterating the lingual sulcus. Frenectomy can be performed before commencing the prosthetic treatment or at the time of denture insertion. Prominent buccal frenum usually does not require any surgical correction because of its compressible and flaccid nature. And the third soft tissue abnormality type is flabby tissue and also inflammatory papillary hyperplasia or denture irritation hyperplasia. And these types are surgically excised as indicated. So coming to bony abnormalities, under bony abnormalities, first one extraction and alveoloplasty. Irregularities of the alveolar ridge found either at the time of extraction or after healing require recontouring before final prosthetic construction. Alveoloplasty is the surgical smoothening and shaping of the alveolar ridge prior to denture placement. And this is the picture. First picture shows irregular alveolar ridge during extraction, and the second picture shows irregular alveolar ridge after extraction. And second bony abnormality is ridge undercut. Small undercut from the ridge crest and undercut only in anterior labial region do not require any surgical intervention. If undercut present both posteriorly and anteriorly, reduction of posterior undercut is required. Bilateral undercut need correction at least one side. And this is the picture that shows undercut present on the maxillary anterior and maxillary posterior region. The first picture shows undercut present on the maxillary anterior region. So undercut present on the anterior region is not required for any surgical intervention. And the second picture that shows undercut present posteriorly on both sides. So undercut present at least one side is required for surgical intervention. And third bony abnormality is prominent mylohyoids. Prominent mylohyoids is covered by a thin mucosal covering. So denture may damage the mucosal covering over the mylohyoids, and the muscular attachment in this area dislodge the denture. The sharp ridge produces pain in this area. So surgical recontouring is done with bone files along with the detachment of the posterior muscle insertion of the mylohyoid muscles. And this is the picture shows mandible with a prominent mylohyoid ridge, and this arrow mark shows the prominent mylohyoid ridge, and this mylohyoid ridge covered by thin mucosal covering, so it is easily damaged by at the time of insertion of the denture. Next one, maxillary tuberosity interference. It is the pendulous tuberosity with undercut is encountered unilaterally or bilaterally. They interfere with the inner arch space, denture insertion, and extension and mandibular movement. This requires surgical correction if they interfere with the normal denture function. Bilateral undercut will require surgical recontouring at least unilaterally. And this picture shows a prominent maxillary tuberosity that interfere with the interarch space, denture extension, and mandibular movements. If the prominent tuberosity is present on either side of the maxillary arch, at least one side is required for surgical intervention. And next bony abnormality is sharp, spiny residual alveolar ridge. This knife-edged ridge commonly occur in the lower anterior region due to rapid labial and lingual resorption. It leads to hypermobile tissue covering the ridge that get trapped between the denture and the sharp bony ridge, causing denture soreness, discomfort, and instability. And this is the picture that shows sagittal section of the knifer ridge in the mandibular handy region. So the placement of the denture over the knife edge in the mandibular hand area that leads to soreness, discomfort, and instability. And the knifer ridge usually occur due to rapid labial and lingual resorption. And next, bony abnormalities, tori and esophagosis. These are relatively common benign condition, slowly growing bony projections of the maxilla or mandible. They attain their maximum size by the third decade of life, and the etiology is unknown. If it is occurs on the midline of the palate, it is called torus palatinus. If it is occurs on the lingual aspect of the mandible, it is called torus mandibularis. The mucosa over the torus is thin and can be abraded easily. So coming to maxillary tuberosity, sorry, not maxillary tuberosity, maxillary tori. Maxillary tori occur in multiple shape and configuration, and smaller tori require only to be relieved because they do not interfere with the prosthetic fabrication. Indication for removal of maxillary tori: first one, speech interference; second one, it affects the posterior palatal seal; and third one, danger instability; and fourth one, undercut torus that trap food debris. So the picture shows a maxillary tori present on the maxillary palatal region. Next one, mandibular tori. Mandibular tori are bony protuberance on the lingual aspect of the mandible and usually occur in the premolar area. Constructing a denture over mandibular tori causes frequent mucosal irritation and sore spot and prevent development of a border seal. Large tori also cause interference in speech. All mandibular tori need to be surgically removed. And this picture shows the mandibular tori. That mandibular tori usually present on the lingual aspect of the mandible on the premolar area, and the placement of the denture over the mandibular tori leads to mucosal irritation, sore spot, and also it prevents the development of the border seal. So, and next pre-prosthetic surgery is the enlargement of the denture bearing area. Under enlargement of the denture bearing, first one, vestibuloplasty, and second one, ridge augmentation. First one, vestibuloplasty. Definition of vestibuloplasty: it is a surgical procedure designed to restore alveolar ridge height by lowering muscle attaching to the buccal, labial, and lingual aspect of the jaws. The main purpose of vestibuloplasty is to obtain more denture extension, and the second one, reposition the muscle attachment to obtain better support for the prosthesis. And next one, ridge augmentation. So ridge augmentation mainly by bone graft. Okay, so it increases the strength of the extremely deficient areas of the maxilla or mandible, and also it improves the height and contour of the available bone. Autogenous graft from iliac or rib source are the most biologically acceptable, but they require an additional and extensive surgery at the donor site. The use of hydroxyapatite alloplastic material eliminate the donor site surgery, but poses problems of the resorption. So the use of hydroxyapatite alloplastic material that cause resorption. The result with regard to predictable recovery of ridge height and morbidity are not encouraging. So, and this is this last one is the enlargement of the denture bearing area. Mainly two types. First one, vestibuloplasty and ridge augmentation. And vestibuloplasty is again divided in three types: mucosal advancement, secondary epithelialization, and epithelial graft vestibuloplasty. And this is the mouth preparation in the complete denture. So the mouth preparation is very important for before the fabrication of the complete denture RPD. Okay, so and today class is over. I hope you all understood the topic. Thank you.